So fun to see. Thank you, Anita. It's so great to see all you familiar faces. I see Sharon Pierce and others. So fun to have everybody here. So thank you for joining us today for the Prevent Child Abuse America Zooming Out speaker series. If you have joined us for previous Zooming Out series, welcome back. Thank you for coming back. If this is your first Zooming Out series, thank you for being here today. We are hosting this Zooming Out speaker series as part of the Prevent Child Abuse America adaptive strategy process. And the purpose of this series is to inform our theory of change. We want to better understand the context and the environments in which we do our work, and that will help inform our future direction. Our speaker today is our very own Dr. Melissa Merrick, President and CEO of Prevent Child Abuse America. Before joining PCAA America, and I believe Melissa, Dr. Merrick has been here with us for 3 years. She was a senior epidemiologist at the Centers for Disease Control and Prevention, where she served as the lead scientist for the ACEs study. I'm sure many of you have interacted or did interact with her when she was with the CDC as well. I had the wonderful pleasure of working with Dr. Merrick on a number of ACEs related items when she was with the CDC and I was with the Wisconsin Children's Trust Fund. And now honored to be working closely with her as we provide national leadership to the field of child abuse and neglect prevention. And so I just want to say, please join me in welcoming Dr. Melissa Merrick.
This is like a new level of hybrid because I'm joined in the room where I am by 9 staff here in the national office in Chicago, and we just moved facilities, so we're getting back together and some people's first days, so we're all gathered in here. So anyway, hello to those in the room and hello to all of you out there. And thanks, Jen, for your kind introduction, and to everyone for being with us today. Let me first try to share my screen and make sure I don't mess that part up. Can you see my screen, Jen? Thumbs up would be great. Okay, great. So just by way of saying, first of all, in terms of our adaptive strategy process, I just want to say a big thank you to all of you on the line today and many, many others. To date, we've really talked with over 475 people. That includes staff and board members and external partners, chapter directors, Healthy Families America, supervisors and home visitors, philanthropy partners. We've also done a survey with over 1,200 adults and families to understand really what do parents need, what do families need in the next generation of this work to really develop a comprehensive prevention vision and comprehensive prevention system. I think you can all agree that we are not where we want to be in this country in terms of how we best support children and families. Our systems are very reactive, where we wait for families to be in crisis to be able to access a lot of the services and supports that would have maybe prevented their entry into child welfare, even healthcare, juvenile justice, other kinds of systems. So really today, the title is Building a Comprehensive Prevention Vision, a Public Health Approach to Prevention. And I think whoever came up with this title really fed it, the bottom line up front. So first of all, comprehensive, that means there's not a single solution, a single strategy, right? We need all of us. We all have a role to play in this work, and that prevention happens in partnership. We need a vision, okay? A lot of us are trained, like I am, in sort of individual modalities, right? I'm a child's clinical psychologist by training, really trained in how do we help one family at a time. And certainly this broader public health view is about population level health, right? What are the big things that we can do for a population to make sure those kids have and families have what they need when they need it before they're in crisis, without stigma, right? All of these things are embedded in a prevention vision. And then a public health approach to prevention. We'll start right there because child abuse and neglect and other early adversity is a public health problem. And that means we have public health solutions. So let me get started. First of all, if you've heard me speak before, you know that I love, love, love this slide. This is by Dr. Judy Cameron at the Harvard Center on the Developing Child. What I really like about this slide is that it really shows a very simple way of understanding risk and protection, right? So as much as we want to tip scales into positive outcomes, then we need those good things in a kid's relationships, in their environments, in their context, right? Those are maybe what many of us call protective factors, safe, stable, nurturing relationships and environments, those protective capacities that help those scales tip to the positive. Obviously, negative outcomes, we would maybe come to understand these as risk factors, right? But not just at the individual level, but also at the community level, in the family level, the societal level, right? And so obviously, if you tip the scales with more positive childhood experiences, protective factors, you're more likely to have positive health and life outcomes. That's what we all want. But a key feature here is you can see the fulcrum, right? And the fulcrum, depending on its placement, you would require more positive or protective factors to outweigh or to balance out those negative ones, right? And we honor, we voice with humility that fulcrum is not equally positioned, right? We know that some children and families start with their fulcrum way on one side, right? And that's a lot about historical trauma, a lot about our social and society and structural determinants of health, right? All the isms, racism, other systems of oppression. We know that systems and policies create many of the disparities that we observe, right? So that's what we would call inequity. And they can perpetuate these cycles of needing more good things to outweigh the whole host of historical and current negative things. So the fulcrum to me is a key part of this graphic, and I really like it here. So really then when we look at what is public health, right, I think during the pandemic, we've all gotten a little bit more understanding of public health, right? Like you can see in this mask picture. So one quick thing, if you could please mute your whatever it's called, your Zoom account. Mute your microphone. Okay, thank you everyone. So, during the pandemic, we know that, public health is what we as a society do collectively to assure the conditions in which all people can be healthy. So it's not what we do, one discipline, one educator, one parent at a time. It's what all of us do together collectively to assure conditions. Again, that fulcrum placement, right? The socio-political context, these conditions in which all people can be healthy, right? So just like early in the pandemic, if I wore my mask, but Catherine next to me did not wear her mask, wasn't as effective at curbing the spread of coronavirus, right? The same is true in any public health issue, okay? So what we do as a society collectively to assure the conditions in which all people can be healthy. So then really, if we look back at this definition, what though qualifies as a public health problem? We know large diseases, mass pandemics and such. Of course, it's easy for us to understand the burden on the public's health, but really there's three simple criteria always that we use to judge is something a public health problem or not. First of all, how many people does it impact, right? Like that's the prevalence. Is it a really small problem? Is it a really big problem, right? And if it's a really big problem, we go to the second factor. Does it impact the public's health, right? So you have some things that are huge in prevalence, like the common cold, right? But the really long-term impacts on a public's health is not so profound, right? People usually, barring any other, adverse health risks and conditions, they pretty much get the common cold and they can recover easily. But other things like childhood adversity, right, stay with us across the lifespan. We'll go into some of that science in a moment. And then third, if those first two qualifications are satisfied, we say, okay, then are there public health solutions that can actually impact all these people that have this problem and that it impacts their health, right? And so, of course, for childhood adversity, like child abuse and neglect, we do have those prevention solutions. So here is the public health model. This is a slide from the CDC, basically just walks you through the different steps of the public health model. So first there, let me first see if I can, oh, that was the wrong thing to do. Okay, wait. Okay. We first define and monitor the problem. This is what I was saying. We identify risk and protective factors. We then develop and test prevention strategies. And then we go to ensuring widespread adoption, right? And it used to be that this was a very linear, kind of like a ladder. And it was only at that widespread adoption that we would do the feedback loop back to define and monitor the problem. Now we see there are all these bidirectional arrows because everything impacts everything else, right? And so when we think about the problem of adverse childhood experiences or ACEs, this is something that, you know, the landmark CDC Kaiser Permanente study first researched in the late 90s. So it's been over 20 years where basically retrospectively adults reported on their early experiences under the age of 18 of these types of child abuse, like physical, emotional, and sexual, other two forms of neglect, physical and emotional, and various forms of household challenges, like growing up in a home with untreated mental illness or with violence in the home, having a parent who was incarcerated or who was substance abusing. All of these sort of, we would call these risk factors for the most part. It's not that simple though, because we know parental separation or divorce can actually be protective in a house that has a whole lot of adversity, right? So we've come to learn that these things are really nuanced and it's not quite as simple as an ACE score, which is a simple count. So as you have more of these experiences, your ACE score would be higher. It does not account for things like the frequency of these experiences, right? Did you experience physical abuse one time in your whole childhood or every single day for 5 or 6 years, right? These dimensions of the adversity are not captured in the ACE score, but still there's some simplicity and understanding that as you have more of these, we can see that you had more adversity, and then we can relate it to the long-term, the acute and the long-term physical and mental health challenges. Just to say, this means too that no matter what population you ask, you get over 2/3 of people in any population, this original sample and hundreds of different populations that have examined ACEs, you see that ACEs are common, right? We think 2/3 of every population has at least one. If you have an ACE score of 1, you're likely to have other ACEs, right? Because we know that they co-occur in the same children and families. So that prevalence thing, it's high, right? We also know through decades of research to date, over 60 health outcomes to date have been associated with early adversity. So it's not just that ACEs happen and impact your direct, physical and mental health in the moment, but they stay with us across life. They affect the way our brains develop, the way our immune systems and endocrine systems function, even the way our genes express themselves, have linkages to those early years. And we see that it doesn't matter what topic you're really interested in, whether it's chronic disease, STIs, like sexually transmitted diseases, other infectious diseases, health risk behaviors like smoking, opioid use, misuse, injury, other kinds of violence and victimization, and life opportunities like graduating from high school, living as an adult, employed as an adult. All of these things have its roots in early adversity. This said, ACEs are not deterministic, right? So if you go back to that original balance, right, it just means that if you have a lot of ACEs, you're going to need a lot of those protective factors and contexts to outweigh that. And if your fulcrum is placed somewhere that you need more, that's also important to note here. But we see over, I think there were 18 or 14 or 18 outcomes on this slide. This is from the vital signs that CDC put out in 2019. I was the first author on this report, but we see that no matter what the health outcome of choice was, right, depressive disorder, you know, it impacts a public health problem in and of itself, impacts about 9% of the population. And we know that if we did not have ACEs in our population, we could prevent about 44% of cases of adult major depressive disorder. You see the same for a whole host. Coronary heart disease, the leading cause of death in this country, could be prevented. We could prevent 13% of those cases if we did not have ACEs in the population. But then here, health risk behaviors, socioeconomic challenges, all of these. So then it means that, you know, prevention of ACEs, right, is an important public health lever if we're going to achieve multiple of our health and well-being, and I would say life, opportunity, and prosperity goals. And I said that ACEs are not deterministic because the science here is telling us that childhood experiences in general stay with us across the lifespan, right? But we have a lot of studies on the bad things, right? Or the stressful things, toxic stress as a field, all of this, which is so important. But we are starting to grow more of our science on what are those positive childhood experiences, positive, safe, stable, nurturing relationships and environments that actually kind of provide the inoculation, if you will, from a health frame, right, to early adversity and help us be with a strong foundation to make it more likely to achieve our health and well-being goals. So I would say then, if we think back to the title of this conversation, it's, you know, how do we have a comprehensive prevention vision and how do we have a public health approach to prevention? It means we have to understand that ACEs don't just come to be, right? It's not like they're just the leaves on a tree that we observe. Where do those leaves come from? They come from these roots, right? And this, if you don't know this slide, this is by Wendy Ellis and her colleagues, the Building Community Resilience Model. And she calls this the pair of ACEs, right? So you have your traditional ACEs, adverse childhood experiences, as the leaves of this tree. And she calls them adverse community environments. I would call these adverse conditions, to get back in that public health frame. But these things that are under the surface, right? These root causes, like poverty, like discrimination, racism, many other things than appear here, by the way, okay? But we're talking about these structural determinants of health, these historical conditions and contexts that really, again, impact where that fulcrum is at birth. Okay, at birth, the fulcrum is not proportionately placed by communities, by a whole host of factors, right? Race being, of course, a critical one. So racism itself is a serious threat to the public's health and would qualify as a public health problem. This is the current CDC director, Dr. Walensky. And I think that this is really important, that the public health agency for our country, CDC, is really owning that racism, other systems of oppression, again, they created the disparities we observe now, right? So we have to move from what's wrong with those people to what did we do as a society, as a culture, historically, that, again, place that fulcrum in different places for different people. So this slide is an old one from 2010 by former CDC director, although many formers ago, I don't know, 4 formers ago, Dr. Tom Frieden. And I really like it, and it's still really true to the way that this work happens, right? We have to prioritize environmental change. Environment, again, those conditions. And it's funny because I learned public health on the job, let's be honest, right? I was a clinician. I'm used to working at that top little part of the triangle, right? Counseling, education, you help one family at a time. And look, that work will always be critical. Okay, that is a piece of this prevention work. And for all of you who are clinicians and practitioners on the line, we thank you for the work that you do. But again, to have that increasing population level impact, if we move to the bottom layers of this pyramid, we know that not only is it less individual effort, but we can potentially help a whole segment of people, right? While still helping in treatment and therapy and other kinds of individual services, the people most at need. But by changing policies, right, those things at the bottom layers, we can really help impact, again, a whole host of our nation's health and well-being goals. So by addressing root causes of ACEs, we can prevent significant health issues and foster healthier and more equitable communities. So for those who haven't seen this slide, this is from our Building Better Childhoods work that we partnered with the Frameworks Institute and Social Current to produce. You can find any of these cool images. I'm pretty sure it's from our Building Better Childhoods work. You can go to buildingbetterchildhoods.org. We don't even put our brand on this, right? We want people to use it if it's helpful for you to use. And this just shows, like, if you know, you're the person at the bottom, the family or the mom, the dad, you have all of these stressors at any moment overloading you, right? No access to childcare or unaffordability of childcare, mortgage, debt, all of that. But then we realize there's also these heavy conditions that are always upon us as well: racism, discrimination, poverty, bias, right, of all types, marginalization. And it is weighing us down and preventing us as parents from bringing our best selves to this important work of parenting. That's why the role of public health in violence prevention is to really be on the left side of this graphic, right? In primary prevention and prevention, they're, you know, meeting people where they are, making sure they have what they need when they need it in the communities where they live without stigma before they're in crisis, thereby stemming the flow of children and families that touch these other systems like criminal justice, child welfare, social services, even healthcare. Right? What this doesn't mean is that prevention is the only solution. So you see, we of course need primary, secondary, tertiary prevention and those trauma-informed systems and responses and solutions. So just quickly, and this is a beautiful slide that I think that Kelly Crane from our policy team made, and it's really happy, and I really like it because it's really happy and colorful, but it also helps us understand what do we mean by these different layers of prevention, right? We want all of them. It's a continuum. We want all of them, but we believe if you move upstream, right? We really believe if you change the narrative, if you put out messages like this Building Better Childhoods content that shows that all of us love our children, all of us are trying to bring our best selves to this work of parenting, but all of us rely on each other. Okay, so back to that public health graphic, it's what we as a society do collectively to assure the conditions in which all people can be healthy and can thrive. So really, we're talking about things for the general population, policies, things like that will really help to minimize risks even before they occur. Secondary would be more targeted prevention strategies for families that have or demonstrate some of the risk factors for having early adversity, such as substance use or other kinds of mental health conditions, to again prevent and minimize those challenges. And then tertiary prevention, we of course also need to focus on families of children who have already experienced early adversity, but because we know that we can change trajectories for children and families over time. You know, when I was leading a lot of this, the adverse childhood experiences portfolio for CDC, I would get a lot of inquiries around, well, don't you think like safe, stable, nurturing relationships and environments like are good, but they're good early and we should stop at like adolescence? Or we'd get things like, well, now it's too late because they already exhibit all of these. No. We know that the brain is malleable. We know that our systems can adapt, and we know that it's never too late to assure nurturing and safety and stability, economic mobility, and all of these things that are going to be protective for families. That said, we know that the cost benefit, right, the ROI, return on investment, is achieved even in a more meaningful, powerful way as we have these solutions early in life, which is why Healthy Families America, other kinds of evidence-based home visitation, these strategies that can really help new families, new parents, and caregivers really anticipate the challenges and really get the supports that they need before they're ever in crisis are the ones that have the most great impacts across outcome. So preventing child abuse and neglect seems big. ACEs seems big, and it is big, not to minimize, it is really big, but prevention is possible, and it's possible mostly in partnership, right? It's something that my team and probably everyone here like laughs. I say prevention happens in partnership all the time, but it's true to how this work, roles. Like as I said, a comprehensive approach, meaning no one entity can do all of the strategies, right? You need partners there. And obviously PCA, we have been around 50 years. Our mission has squarely been on prevention, although I will say that we're more poised now than ever before to actually really rally our partners, our state chapters, our Healthy Families America networks, and all of you and all your friends to really create this vision where all children are happy, healthy, and prepared to succeed in supportive families and communities. Again, we know that children thrive and children are safer with their families than from their families if their families are supported without stigma and before they're in crisis. So CDC, again, our public health agency for our country, has a whole toolkit for us. These are from their technical packages. This is from the technical package on ACEs, where we've basically just tried to get the best available evidence of strategies. But if you specifically are interested in preventing sexual violence, they have a tool, a technical package on that. Preventing youth violence, preventing suicide, intimate partner violence, and child abuse and neglect specifically. And then all of the strategies that are really for children and families under the age of 18 were pulled together for this ACEs package. So here you can see kind of these different buckets. And I will say that what's compelling is that a true comprehensive approach, you would literally have strategies in each of these buckets, right? And like I said before, we're not all of us in like places where we can impact each of these buckets, right? We might see ourselves more downstream on lessening harms and preventing future risks. That tertiary prevention stuff, that's also important. I will say for us at PCA America, and I think what's needed for our country in terms of making maximum population level impact, we need to double down on these first couple, strengthening economic supports for families, right? These things like strengthening household financial security through livable wage, through tax credits, right? Family-friendly work policies like paid parental leave. These kinds of things have impact on preventing child abuse and neglect and other early adversity. Also promoting social norms that protect against violence and adversity, right? You can see some of the strategies listed there. And then of course, ensuring a strong start for children and families through things like high quality, affordable childcare, things like evidence-based home visitation, like Healthy Families America, which is our signature program. And then again, all of these strategies together. PCA America, of course, addresses these strategies across our core pillars, but what we've heard loud and clear from all of you, I mentioned the 475 plus people we've talked to, over 1,200 parents that we've heard from, is that you want us to take a leadership role in providing thought leadership for the country, and really defining what would a primary prevention ecosystem look like, right? How would we make sure that there are healthy and secure family relationships that support child and family well-being? How would we make sure there's equitable access to formal and informal supports and foundational life skills? How can we move from not just wanting financial stability, but actual economic mobility for families, right? These are things that we can't just espouse these kinds of values and talking points. We need to live them, right? We need to operationalize what that means in various communities. That means we need to listen to families, to communities that understand very clearly what their challenges are and what the opportunities are for their health and well-being, because we really, again, want to design a child and family well-being system where really primary prevention is seen as the key to population level health, to achieving our nation's health and well-being goals, and to have race equity squarely in the middle of all of that. Okay, it's not an add-on. It's kind of like when you used to read legislation, it would really be legislation about treatment, and then they would just tack on the word prevention as if that was meaningful in some way. I think that's kind of where we start, where people finally understand, like, there are these buzzwords and they must be important, and while they're figuring it out, they use these words. Come on, guys, we know how to implement these things, right? We have toolkits, we have evaluation, we know what best practices are. So it's important that we continue to recognize that our systems perpetuate these kinds of disparities, but that means that we have the power and the ability to change outcomes, to change trajectories. And so we want, instead, for these good things to lift up our parents, right? And instead of weighing us all down, we want to be lifted up by all of the services, supports that would exist in every community, delivered by people who look and feel and like the people that live in the community, that you could trust, that someone's not coming in and telling you what to do. Please, that's not effective. That is not effective. So these are the things we want. And of course, again, if it's about population level health, I think this is another Kelly Crane slide. I like it. It just gives us, this what's possible, right? We know what's possible. We know how we can have maternal and child health policies, right? Economic stability tactics and supports, early childhood supports, mental health access and supports, community and education and awareness building, all of these. And again, I'm asked a lot, Melissa, but if I could only do one of them, which one is the key one? That's going to vary by your context, right? You know your context, you know the conditions in your local communities, in your states, in your entities. But again, there's power in partnership. You may be able to really have a lot of bandwidth around evidence-based home visitation, right? And you want to partner with another group or entity in your community that's really about pre-K and after school supports, right? That's all part of this prevention continuum. So I think in some ways we sometimes have to just have a lot of humility. Like, it's not going to be any one of us doing all these things, but that doesn't mean that we shouldn't all align with what the vision is and see how all of the great stuff that we're doing contributes to that vision. And ultimately, these are more building better childhoods graphics, but ultimately we know that preventing child abuse and neglect and other ACEs has to be a public issue, right? It has to be that we all have a role to play in bringing forward these solutions, and that it is preventable and solvable. You can learn more, of course, about these topics and others at our conference. We have a national conference every 2 years. We're really excited to be back in person this August in Baltimore, August 22nd to 24th. There's a little QR code there. You can go straight there and register. I think the call for proposals will be out soon, February 1st. Hot off the presses, February 1st. But you can see here, Together for Prevention. This is how this work happens. It's about building a national movement, which I believe we're all squarely a part of. And so how do we honor the generations of work that have come before us in this field, right? And how do we then invest in a generation of children and families to come? Because we know that childhood lasts a lifetime. So we can really build the foundation to help prevent child abuse and neglect and other early adversity. So with that, there is one last slide. I'm not going to even pretend like I know how to share a video, but I just want to let you know that if you go to buildingbetterchildhoods.org, you may have to put your name and your email address to sign up, but then there's this great 3-minute video that basically says almost everything that I said in 3 engaging minutes. So you can certainly use that as a resource. So with that, I'll stop sharing and see what Jennifer tells me I didn't talk about and I was supposed to talk about. And I'll be really interested in what you all are thinking as you listen to those comments. Jen, to you.
Great. Yes, great. Thank you so much, Melissa, for those inspiring words. I mean, I think we've known each other for about 15-ish years or so, and I feel like every time I hear you present or speak, I learn more. So we are so fortunate to have you as our leader at this time in our history. Your vision and your passion for creating the conditions for all children and families to thrive is incredibly motivating, and should rally all of us here on the phone and all of us across the country to want to follow your lead. So thank you for being here and sharing that with us. So I have a few questions, Melissa, that I would like to ask you. And then we can certainly open it up to the audience, or the audience can feel free to put questions in the chat. We'll get to as many of them as possible. The first thing I'm curious about, Melissa, you talked about the ACEs study in your presentation. I think a lot of us at this point in time have heard about the ACEs study. But I'm curious, from your perspective, why do you think it took so long for our field, the prevention field in particular, and even child welfare, to understand the research behind the ACEs study, and then to use that science to inform our practices and policies? You had mentioned it's been 20+ years since the study came out. I think now we're probably a little bit over a tipping point, but it's been some time. And so just curious from your perspective, what might be the reason that has taken us so long?
Yeah, sure. I think a key reason is that we like to talk to people that already roll in these same spaces, right? We talk to each other, we bring awareness, we present at academic, conferences, and look, it's important. It's important that we slowly get the message out, but it's almost more important for us to talk to people like business, like lobbyists, like policymakers, like people who don't eat, breathe, and sleep science and early adversity impact on the brain, right? Or these kinds of things. So I think that that's one important part, is bringing this information in a relatable, accessible way to lots of people who have different skill sets and different thinking and different metrics and different possibility, right? So I think that has taken us a long time. I also want to say that the ACEs study, although it's a seminal study in this area, it's not all of the work that we know, right? There are people that have been in any of these topics, child abuse and neglect, sexual violence, substance use and misuse, who have also been putting out this science. And so I think sometimes we were very protective of, no, but this is ACE work, or this is child abuse work, or this is, versus when we look at what the solutions are going to be, we said we want population level solutions. We wanted everyone to have a role. So we actually have to get out of our own way and recognize the true spirit of partnership, even in our topics, right? So there's some people again, that want to study the 61st, 62nd, 63rd health outcome from ACEs. For me, that is not innovative. I think we have all the evidence that, guess what? ACEs impact all of us, every community, every population experiences ACEs. Why not just bring the good prevention solutions to bear in any community, right? Again, our funding in this world is not organized in that way, right? We see the RFP or the NOFO, it comes out, it says, no, I want you to specifically measure the outcome on child abuse and one other type of violence, right? That's one that we have, right? Okay. But it kind of sometimes can limit what is actually possible, right? And someone may see, even in our name, Prevent Child Abuse America. I mean, we're not going to talk about that today, but sometimes that can be a little bit oh, those are child people, or, oh, those poor children, we got to save them from those families. That is not what we're about, right? It's the prevention part. It's the making sure everyone has what they need when they need it before they're in crisis. That again helps us prevent child abuse and neglect, but it also helps us prevent all of those health outcomes that I showed on the graphic, right? It also helps us achieve more equitable outcomes for life, prosperity, and health and well-being at a system at a national level. So I just think that we have to do better by honoring what's possible, right? Prevention is possible. So we want to elevate that possibility. We can only do that by being bold, by understanding the science and getting to the solutions. And then again, I think making sure we partner with like-minded and not like-minded people in all sectors to really achieve change.
So you alluded to some of this a little bit, but how do you think we get better at being quicker at using the science to inform our work?
Well, first, I want to honor the comment in the chat by one of our new board members, Dr. Lally McDavid, because I may have neglected to say in my really brief overview of the ACEs study that the seminal study was conducted with a very have population, right? They were mostly white, mostly middle class. All of them were insured by nature of it being an HMO sample. And still we saw that 2/3 of them had at least an H score of 1, right? And it affected their health and their well-being. So when we add the different conditions and contexts, we understand that the load is even heavier, right? For our Black and Brown and Indigenous communities. And that's a problem, but it also means that many of those disparities were created by our systems and by our historical traumas and circumstance. And that means that it's within our reach to change those policies and systems to create a true child and family well-being system, right? Where people have equitable access to the things that they need without fearing that the only service they're going to get is that their kids are going to be removed if they ask for help. Right? We all know that's what we're dealing with, and we know that something needs to change. I didn't even really hear your question, Jen, so if you want to repeat it, that'd be good.
No worries, but I actually want to go, I'll go back to that. I want to go to someplace else for the moment, which is, sometimes we hear in our field, right, in the child abuse and neglect prevention field, that addressing equity and addressing systemic racism isn't really our work, right? So curious to hear, and you talked about some of this in your presentation and your remarks, but what role do you believe we as a field, and I mean child abuse and neglect prevention field, need to play to address the conditions like systemic racism and inequities?
Yeah, I think it's such an important question. We get it a lot. I also want to just honor that everybody on here has a slightly different context, right? Depending on the state that you live in, the community you live in. Is it red, blue, purple, orange, there's all of these things that come to bear. And the word equity in and of itself could be something that really stops the conversation from actually achieving any of these outcomes, right? Or putting in the solutions that we're going to say are a comprehensive approach. So knowing your context is so important. And I know some of us, I've been accused of being in la la land sometimes, right? Or being really positive or optimistic. But I think you have to sit with that discomfort that we all maybe don't jive well with the context that we're in, but we have to navigate and negotiate in that context. So I just put that as a frame to say it's going to look different places. That said, when you operationalize what it is that you want people to have access to the things that they need to take the edge off, right? We need childcare. We need to be able to afford childcare. We need to be able to know that when we're not able to care for our kids, if they're at school or after school, that someone with their best interest or some place with their best interest at heart is safe for them, right? Is going to nurture their spirits and their minds and their passions, right? We need all of these things. We need that, that people can afford to feed their families, right? That they have food security, that they have stable housing, that they're not worried about, lead paint poisoning. And there's a lot of stuff. I think this is where it's like, if you go down too far into the rabbit hole of all the things we need, it can definitely seem overwhelming. But I see it on the positive. There's a role for all of us, right? Of making sure families and children have what they need when they need it in their communities, right? They can't like not everyone can travel to a different place to have the best intervention, and this is why home visitation is so compelling, and there's such strong science. It meets families where they are to navigate the challenges that they see for their families, not the ones that we say you better fix this and do better. So I think equity, it just is this work. I think how we communicate equity changes depending on our context, our partners, our champions around the country. And that, to be honest, I think is the key ingredient, right? It's like not assuming that we all mean the same thing, even when we say equity. I would say, I will just be really transparent. I think people in this room maybe all have a slightly different understanding of what equity is, or what it looks like for their families or for their communities. And that's okay. Right. And that's okay. Doesn't mean that, you don't care about someone else or you don't have empathy. Right. But we can't let definitions and like reactions like keep us and hold us back and make us do what we've always done. Because guess what? I mean, I'm a psychologist, but I think all of you know, if you do what you've always done, you'll get what you've always gotten. Right. And what we have now are way too many kids in our systems, right? Way too many kids separated from their families or from their communities, way too many families blamed and shamed for things that we created as a country, as a history, as a society, right? So sitting in that discomfort, I think, is part of the journey. Of course, all of us want to say, all right, we're going to do something right now, right? And we don't wait always for the evidence. I think you're right in the ACEs science and such. Like we maybe waited a long time before we, used those learnings for prevention action. But we're there, we're there, and we have the right partners and people on this call, and everyone who's been talking to us and sharing their visions and hopes for the future with us. I think prevention is possible, and we need to get at harnessing that possibility.
Awesome. So I just want to point out, Kirsten put this in the chat, but we, Prevent Child Abuse America, commissioned Frameworks Institute with funding from Annie E. Casey Foundation to write a strategic brief on the impact of racism on child and family well-being. So it's talking about racism in child and family well-being advocacy. We're doing a webinar on February 1st. So encourage you, any of you who are really interested in, more about this conversation that Melissa just shared with us, to please join us for that webinar. It looks like Jim has a question, so I'm going to ask him to come off mute and ask his question or comment.
Thanks, Jennifer. Thanks, Melissa. It's a great presentation and love the information. One question I have, and it's kind of an emerging issue for us in West Virginia, and I think nationally too, with the conversation about the role of child welfare systems. And there's a growing move towards abolition of those systems, and the prevalence of a family policing system, as Dorothy Roberts calls, and then the reform efforts and in the different space. And I was doing a presentation in December looking at trends and talking about some of these things, including the pair of ACEs and moving upstream. And it occurred as I was doing this, we have the river metaphor that I think probably everybody here has heard, where you build a system to rescue the children, and those of us in prevention are moving upstream and then ultimately addressing the community conditions that are causing families to be in stress. But what about the system when we look downstream, when we also know, and I'll just place West Virginia at the spot, not to characterize other states and their systems, but some parts of West Virginia, the systems that are set up to rescue children from the river are actually harming the families they are intending to serve and to benefit. And we're taking, newborns from a mom who's maybe walking across a little bit of a creek and, trying to connect the dots from rock to rock, if we keep that metaphor going, but is not a, torrent of a rapid river. And the child is not by themselves in this river. They are being held onto by family and extended family. And so we're kind of wrestling with that work, because we are primarily a primary prevention, policies, economic supports, protective factors. But then we also see, really disproportionate impact of our child welfare system that is intervening with families in ways that we know from the science are not ideal and actually are harmful in some cases. So it's got us in this kind of tension space where we're getting more and more into child welfare reform. We're trusted by policymakers, but there's this tension. So I'm just curious, the wisdom of this group, your leadership, Melissa and others, because that's part of public health too, is when the interventions themselves are not effective, we learn and we, tweak the immunizations, we tweak the mask mandates and so forth. And yet we've been, I think, largely as a organization, this is our lane. So I'm just curious. I don't have an answer or even necessarily a question, but wanted to bring that to this space and this conversation about public health and that river analogy.
I love that you brought it up, Jim. And let me just say, unfortunately, West Virginia is in good company, right? This is what the system looks like across the country. We know overall, like just, 2-to-1 for Black, families in the system, 5-to-1 if you look at families with low income versus families with, basic income, if you will. And so what you're speaking to is the critical importance of recognizing that those systems not only are not primary prevention, right? Because we have to wait for families to be in crisis or for their families' conditions and context to be deemed to be a crisis, right? When it may not be, right? It might be that the mom needs to do her rehab treatment with her baby, which actually has outcomes that show that it's best for the child and the mom in healing, right? So, I mean, you're talking about a whole lot of things, but I think this is where this real transformation to a child and family well-being system, that's why it has such traction around the country, right? It's like looking at the big circle, like right now we have this, child welfare system where the majority of the intervention is in removal or is in getting into that system to access those supports, as opposed to what if you could access all the supports and there's only one little small piece for those families who really need that intensive, whatever, where removal would be. So I would say, abolition, transformation, there's all these words all over. I will say that the science is pretty clear that what we're doing is not working. It is not associated with the most positive outcomes for children and families, certainly for children that even age out of foster care, right? And transitioning back. I mean, that's a whole other conversation that we could have, that many of you I know have had around your states and your communities. But this, ability to kind of transform the narrative from mandated reporter to mandated supporter. I know that's something that we've talked a lot about, PCAA nationally and in Arizona and other communities. I even just saw a big ACF funding announcement come out that really is about that, moving from mandated reporter to supporter. There's even an initiative in New York City right now that's called like mandated reporters against mandated reporting, where they literally just say, if these are the risk factors, then what are the other resources and referrals that can be made right here that don't require kids to be moved, out of their families and their homes. So I think what you're talking about is really important. We have to honor that as a big piece of this work. Again, the prevention continuum means that once families get into child welfare, we can still have prevention services and solutions. I will say that what will not work very clearly is to take our current system as it is, child welfare you are specifically talking about, and tack on that they're going to also do prevention, right? Do everything else you're doing and then also do prevention. First of all, that makes prevention meaningless. It also, like the strategies that are already implemented are not working. And we're governed as a child welfare workforce. They're governed by fear, right? Fear of getting it wrong. Like what happens when that child that they put back with a family without supports often, dies and there's a fatality. And look, all of that is like what we're trying to prevent. But the truth is you cannot maintain a system based on fear, based on, instead, it has to be what are the good services and supports and concrete supports that we provide once kids are removed from their homes. Why not provide that to keep kids with their families when that's indicated, right? So I think what you're bringing up is a really important conversation. I'll pause and see if anyone wants to chime in with other ideas or reactions. You can also put it into the chat. But it's really important, Jim.
Melissa, it's Sharon. Having been involved early on in the Thriving Families Safer Children initiative, I'm wondering, are you feeling like that's continuing to get some traction? That was really the intent of that effort. And certainly Prevent Child Abuse America and Casey were very active partners, but just maybe a comment on where that is and whether that is one hopeful piece of, the solution that Jim's raised.
Yeah, thanks, Sharon. Yeah, that movement is ongoing. We have about 23 jurisdictions that are working at the community level to bring solutions, right, that are co-created by folks in the community with lived expertise alongside the national partners. There's now 5 national partners. It was PCAA, Children's Bureau, Casey Family Programs, and Annie E. Casey. The CDC recently came on as a 5th national partner, and I think that just helps to really bring that science and public health approach to communities and to really help us all operationalize what are those assets, right, that you need? What are those protective factors, again, that's going to tip the scale for those communities and families? I will say that this is different. It's going to take a while. I will say what I think the key to change is that we change the way we fund these kinds of efforts in our country and that we invest in a generation of children and families. That's what we've done with the tobacco, the car seats, the booster seats, seat belts, all of those, took a generation to really implement, right? And to see the good outcomes. So I think that's my hope, is that together, all of us can really focus on investing in a generation, 20 years of children and families. Then we can measure all of those downstream impacts that improve, right? When we help support families in the first place, where they are without stigma before they're in an acute crisis.
Thank you. Thank you again, Melissa. We are here at the end of or at the top of the hour, so the end of our hour. Thank you, Dr. Merrick, for your words of wisdom, your leadership, your incredible passion, which comes through whenever you speak and present for kids and families in our country. I do want to say, please join us for our next Zooming Out session. It will be on February 13th at 10 a.m. Central, and it will feature Raquel Hatter. She's the managing director of the Human Services Program at the Kresge Foundation, and she's going to talk with us on the social sector's role in disrupting the status quo. So going to be a great conversation and presentation. So please do join us for that. And thank you again, everyone, for joining us today. Have a great week. Feel free to reach out if you need anything. And everyone take care. Bye.
Thanks, everyone. Bye.